opportunity to give this talk. Indeed, we have a very large experience in the field of home parenteral nutrition. As mentioned by the previous speaker, we report last year the largest pediatric cohort on home parenteral nutrition. In France, we are not the single to perform home parenteral nutrition, but we have certainly the largest area because we take care of children of the West, of the East, explaining the fact that we have a large cohort. But to set up a multidisciplinary team for home parenteral nutrition, we need to have experienced pediatric gastroenterologists and nutritionists, pediatric surgeon, registered expert nurse, pharmacist and biologist, dietitian, nutritionist, psychologist, physiotherapist, social worker. And I forgot anesthesiologists, which are key person for inserting the catheter. The training of the parents is a crucial phase, pre-discharge phase before any home treatment. The parents training lasts between 2 and 3 weeks, performed by expert nurses, supported by parenteral nutrition guideline and specific documents, movie, video, and cartoon, and finally a pre-discharge testing of the parents performed by both the nurses and the referent physician. The parenteral nutrition bag are mostly on the 2-compartment bag. They are rebuilt just before infusion in ternary mixture. And the pump are very, very easy pump that can be transported easily. The weight is very, very low. And the organization of home parenteral nutrition is as follows. The hospital is responsible for the clinical evaluation, the biological evaluation, and the prescription of what we call à la carte, that means compounded parenteral nutrition bag. And the bag is made by the hospital pharmacy or by a private compounder after dose warning control. And compounding for us is performed by Façonnut, which is a private company working perfectly and ensuring both the delivery and the manufacture of the solution to be able to offer to the family a family daily life acceptable, improving the quality of life. And if you look at the French experience, last year to this year we have not the final data, but last year 307 children were managed at home, representing around 20 per million of inhabitants below the age of 20, and it's an increased number from the previous year of almost 15%. That means home parenteral nutrition is an increasing activity. The main cause of intestinal failure requiring home parenteral nutrition are as follows: short bowel syndrome, congenital enteropathies, intestinal pseudo-obstruction, and extensive Hirschsprung disease, aganglionosis. And if you look at the home parenteral nutrition duration, it's a duration in months, it's a median, but according to the large population, the duration is around more than 60 months, that represents 5 years in mean. And the catheter we use are especially silicone cuffed catheter instead of chamber. And if you look at the national data, we are in Necker using a few arteriovenous fistula. In Lille, for example, they use chamber, like in Toulouse or Marseille, but chamber are very, very rare in the pediatric practice. But we are inserting chamber in an increasing number of adolescents because they ask to have a chamber. And the vascular access are corresponding to skin handling promoted by the guideline, as well as the dressing method. And as mentioned by the previous speaker, the daily care of the catheter are totally crucial for the prevention of catheter-related sepsis. In terms of non-recommended practice is inline filters, routine replacement over guide wire in case of infection, and the systemic antibiotic prophylaxis. The thrombosis and occlusion may be prevented, but without evidence, by using heparin, and for catheter accesses intermittently, flushing and heparin are recommended. But in our personal practice at Necker Hospital in Paris, sharing the most important cohort, we have performed and published last year this monocentric cohort study involving children below 18 years of age enrolled in the program between January 1st, 2000 until December 31, 2013. And we review from our database. And what is interesting to see is that the turnover is permanent with people with children entering and exiting from the program. And what you can see here in blue is those patients from the region of Paris, and in red, outside Paris in the west and east of France. The indication for home parenteral nutrition are primary digestive disease for most, 86 patients, and non-primary digestive disease, including immune deficiency or metabolic disorders. And this rate, this incidence or prevalence of non-digestive disease is decreasing because I don't know the reason. But today, when I am talking to you today, almost 98% of the patients are suffering of primary digestive disease, involving the short bowel syndrome in 60% of the patients. If you look at the result, only or as much as 140 children were weaned off parenteral nutrition during the period of the study, after a mean duration of parenteral nutrition of 2 years. 87 children are on ongoing home PN. 12 have been transferred to adult units, and 9 children restarted HPN after being weaned, and 19 have been transplanted with isolated or combined liver-intestine transplantation. The overall survival, including digestive and non-digestive disease, is as shown on this cartoon. And if you compare the primary digestive disease, including those patients who have been transplanted, and the primary non-digestive disease, metabolic and immune deficiency, all died during the study period. But for short bowel syndrome, if you compare the survival in the previous period before 80 or after, and it's a continuous increase in survival of the patient. Today, I do consider that a child discharged on home parenteral nutrition should not die. Intestinal transplantation was performed for some patients, 19, from the Necker HPN cohort, and in which some patients were referred to us for both home parenteral nutrition or intestinal transplantation. We performed 14 isolated and 5 combined. And after 3 years of parenteral nutrition for a mean. And 95% were weaned off after 18 months post-transplantation. But unfortunately, intestinal graft has been removed in 7 out of 19 children. That means 35%, 2 years after the transplantation. 3 children died after intestinal transplantation. What about hospitalization and sepsis? We have the obligation to admit patients, especially for not intestinal failure, for catheter-related sepsis, which is the main cause of hospital admission. And the duration of hospitalization in that setting is both from this cohort study, 25 days per year, which is high. But now with the decreased incidence of catheter-related sepsis, we can expect that this rate of admission will decrease in the future. And the cause of admission, hospitalization, were mostly for catheter-related sepsis and mostly for septicemia, almost 300 episodes of septicemia during a 15 years study period. And 34 children had at least one septicemia. And it is the reason we decided to introduce in our practice the taurolidine lock. And as shown by the previous speaker, the cause of catheter-related infection were well described between the cutaneous cause and the biofilm and the thrombosis. And this was shown by the previous speaker, showing that the most frequent infection is caused by Staphylococcus epidermidis. And by using taurolidine, we move the incidence from almost 2.5 to below 1 catheter-related sepsis for 1,000 days of parenteral nutrition. You remember the number in the United States, almost 9. And taurolidine for us makes the difference. And we are following the guidelines of the EBSGAN that will be published on that topic, especially next year. And there is no bacterial resistance currently reported by using taurolidine lock. Ethanol lock is not in our practice for all the reasons exposed by the previous speaker very, very nicely. And regarding intestinal failure associated liver disease, as you can see, the question is remain the definition and the diagnosis criteria. We will not enter this discussion, but according to our own criteria, involving cytolysis, cholestasis, or both cytolysis and cholestasis, we have seen that only 51 children, 20%, had high FALD, which is quite a low rate. And in those, we have done a workup in the view of transplantation, very few. Here in yellow, it's 24, no fibrosis, and only few, 16% had cirrhosis requiring intestinal transplantation, which is low. But most of these patients, even with cirrhosis, continue to survive without transplantation. Regarding the cause related to high FALD, we have seen a significant correlation between congenital enteropathy and the incidence of high FALD. And in terms of growth, because growth is one of our main concerns, as you can see, after parenteral nutrition weaning in short bowel syndrome, they continue to grow with no difference at the time of weaning and 6 months post-weaning. That means we cannot accept to wean off a patient with short bowel syndrome from parenteral nutrition without a perfect optimal growth. If we compare with other studies reported in the literature, this one from Italy, this one from France, Italy, you have some difference, especially in terms of mortality and in terms of high FALD and catheter-related sepsis. And the lowest rate, fortunately, is observed in Italy by Diamanti, and the highest rate in France by the Lyon team. And the incidence of high FALD is the lowest in our cohort. The modification we have done during the last decades are as follows. On washing method, the change, the utilization of auto-flush Vigon device, the skin handling by using chlorhexidine and not betadine, to use the SMOF lipid emulsion, and to introduce the taurolidine lock. And with the addition of one more expert nurse, 440 children today on home parenteral nutrition, we are quite comfortable, but nurses are never sufficient. We always ask to have more and more and more. And the use of lipid emulsion, as mentioned by previous speaker, changed over time from the first generation based on soybean and the last generation based on fish oil. And I would promote the use on a long-term basis of SMOF because it's a very interesting composite emulsion. And in our practice in France, as you can see, the dose are around 2 grams per kilo per day or almost 2 grams per kilo per day. And the use of SMOF is very, very large because most, if not all center, except one, is using SMOF lipid. The one who don't use SMOF lipid for all patients is because of pharmacy procedure. But SMOF should be recommended on the long term. In conclusion, we can consider that home parenteral nutrition remains the first-line treatment for children with protracted or irreversible intestinal failure. Mortality is low and mostly related to non-digestive disease. In SBS children, growth is correct and remains as well 6 months after parenteral nutrition weaning. HPN program requires medical expertise and logistics for reducing complication rate by using Torolog, by using SMOC versus intralipid, and a multidisciplinary decision for the best therapeutic strategy in case of irreversible intestinal failure should be performed by a multidisciplinary team, including medical doctor and non-medical professional, because it's an ethical issue that should be discussed very carefully. Muchas gracias por su atención.